I'm Mary Lloyd Ireland, and I was honored to be asked to speak at the Houston Society meeting. My talk was on ACL reconstruction and return to play. This is my website, marylloydireland.com. I have nothing to disclose. During this talk, we'll go through osteoarthritis, what reduces the risk of osteoarthritis, post-traumatic osteoarthritis after ACL reconstruction, stable knee, normal menisci, normal gait mechanics, negative family history of osteoarthritis, and biologic factors. And the return to play testing is similar to prevention programs. Post-traumatic OA occurs in 50% of patients with or without ACL reconstruction. The factors are biomechanical, surgical, genetic, return to play, and a combination of all of these. Recently, Hewitt wrote an article in Sports Medicine questioning should return to sports be delayed until 2 years after ACL reconstruction. At 2 years, young active athletes returning to high-level sports are less likely for a second ACL injury, more likely to regain knee joint biologic health and function. And the question is, would this delay development of OA? It's a hard concept to accept in these young athletes who expect to play and go back to soccer as a 15-year-old. Highest risk for ACL re-injury wants to go back in 4 months. So if you tell them it'll be 2 years, they will probably go shopping for another surgeon or another concept. But if we're trying to protect the health of the knee, prevent osteoarthritis and re-injury, longer return to play is probably better. Whether the parents and the athlete agree with us in their tunnel vision to return to play quicker, get scholarships, remains to be seen. Development of osteoarthritis, we need longer-term registry follow-up in our country. In this article by O'Connor, there are differences comparing the sex in osteoarthritis of both the hip and the knee. This is a patient who is 2 years after ACL reconstruction and developed progressive tri-compartment osteoarthritis. After previously I was treating her for patellofemoral osteoarthritis, which is here. So this is her after 2 years ACL reconstruction and a professional basketball player. Development of osteoarthritis in the Swedish ACL registry, 84 female soccer players, 12-year follow-up, 42% symptomatic knee osteoarthritis, 75% symptoms affected their quality of life. There was no difference if they underwent ACL reconstruction to those compared who had not done ACL reconstruction in the development of osteoarthritis. So about half of them got osteoarthritis. This 36-year-old professional basketball athlete who I showed her 2-year follow-up picture, an allograft ACL reconstruction was done by another surgeon. This is her injured side, so pre-ACL reconstruction really looked pretty good. She had on the opposite side some patellofemoral osteoarthritis. ACL reconstruction, you might say that maybe the screws were too vertical in the tunnel, but bottom line is she developed post-traumatic OA very quickly that was tri-compartment. This is 3.5 years with increasing knee pain. So she's now almost 40 with basically a knee that needs to be replaced. So is there a pack year of knee repetitive activities, such as how many years of basketball should we be playing? As in smoking, is it the additive effect of years of participation in basketball or other sports or training? So we can think of pack years of activity on knees, and maybe there are too many pack years of playing basketball. ACL reconstructions, we have come a long way if we look at how we did ACL reconstructions in the past. From the 70s to the early 80s, we did extra-articular IT band tenodeses a lot of different ways. Andrew's mini reconstruction was very popular. We did arthrotomies and open ACL reconstructions. One of the problems was stiffness and not regaining full extension because of our casting, our rehab techniques, and our operative techniques of arthrotomy extra-articular. In the mid-80s to mid-90s, we shifted to do arthroscopic ACL reconstruction single bundle transtibial femoral reaming. We did forget about some of the medial lateral ligamentous injuries and concentrated more on just doing the central ligament. We now understand that the medial lateral restraints are very important to restore if they're torn. In the mid-80s, anatomic ACL reconstructions popularized. Single and double bundle transmedial portal femoral reaming was started, so we're making things more anatomic. I never jumped on the double bundle train, but putting a single bundle in the right spot makes sense. We've had improved fixation techniques since 2010. And now it's interesting, we're turning to the IT Bantina DCs that were more popular in the 70s and early 80s before we could do all these things arthroscopic. The anterolateral ligament, is it real? Can we repair it? I think not. We will be revisiting different IT Bantina DCs and trying to decide who we should add this in that high-risk patient, perhaps the patient that hyperextends 30 degrees, to supplement anatomic ACL reconstruction. But the ALL may indeed not be real and be a very small capsular attachment that we see with a Sagun fracture. I don't think we can think a repair of that capsular ligament is going to make a big difference. So when we correlate the mechanism of injury, anatomy, surgical findings to the study design in the lab, this is the anterior drawer and exam under anesthesia. On the right is the arthroscopic picture. You can see the stump of the ACL here. Nothing attached to the wall, so the tibia is anteriorly translating. And what we have is a lateral tibial plateau that rotates anteriorly. And that's the pivot shift. Pivot shift occurring from 30 to 0. This shows the pivot shift test. You can do a reduction or a subluxation test. In the dislocation test, internally rotate the tibia from 30 to 0. It subluxes anteriorly. Shift, so it's subluxed, so it's reduced. Now it's subluxed. You can do a reduction test, put a little axial load on the foot, and gently, it's a finesse maneuver, not a brute maneuver. The medial compartment is extremely tight, and when you tear your ACL because of that rotation that occurs, we oftentimes see peripheral medial meniscus tears. It's very tight in the medial aspect of the knee, and sometimes it's hard to get your sutures back there, but we must look and repair the menisci if they get torn. So a lot of compression forces in the knee medially. This is my website, marylloydireland.com. Please visit it. There are presentations such as this one narrated on the website. Also publications, travel, other links. Thank you very much from Lexington, Kentucky, the University of Kentucky Medical Center. These are our references.